Now let's see about the treatment part of kidney stones. Whenever there is a patient coming to you with severe renal colic, what you have to do is first treat the patient with painkillers and IV hydration, for example like ketorolac, and then you would give some antiemetics to stop the nausea and vomiting if present, and you can give calcium channel blockers like nifedipine. This can reduce spasms of the smooth muscle, because when the ureter is a smooth muscle, whenever there is a stone, there would be spasms in the ureter, which would cause severe pain. Giving nifedipine would reduce those spasms. And tamsulosin, which is an alpha-1 blocker, can reduce the tone of the spasms of the smooth muscles. So the pain would subside. And then, after stabilizing the patient, we would give medical management. If the stone is less than 4 mm, that is usually said to pass out spontaneously. Or we can give thiazide diuretics for calcium stones. We know that thiazide diuretics usually absorb back calcium from the urine. So there would be less calcium in the urine. So there would be less chances of forming a calcium stone. And if the calcium stone is present, it can dissolve it. And we can alkalinize the urine for uric acids and cystine stones. These stones are usually formed in acidic urine. So what do is we alkalinize the urine so that these stones would not be formed. Then for uric acid stones, we can treat it with the gout drugs, the allopurinol. And since struvite stones are usually associated with UTI, we tend to give antibiotics for struvite stones. So that is why it is important for you to know about different stones, so that the medical management for each would be different. Now let's talk about the surgical management. The first one would be extracorporeal shock wave lithotripsy, that is ESWL. Extracorporeal means outside the body. From outside the body, you give a shock wave which can break the stone, that is lithotripsy, break the stone. So from outside you give a shock wave which can break the stone. That is how this procedure works. Now this is a non-invasive transfer of waves to break the stone. It means this procedure is not invasive. So that would be a huge advantage for the patient. This is usually successful if the stone is less than 20 mm in size or 2 cm in size. It is difficult to break very big stones. And it also depends on stone density. Earlier I said that cystine stones are very dense and very difficult to break. So cystine stones are usually not breakable, so ESWL is not used for cystine stones. The next thing we see here is Pcnl, that is percutaneous nephrolithotomy. Percutaneous means via the skin you go into the kidneys to break the stone. If you see here, you make an incision in the skin, go to the kidneys and break the stone. You can use an endoscopy to remove the stone, or you can use some lasers to break the stone. The complications of Pcnl is hematuria and hydropneumothorax, the most common being hematuria, blood in the urine, because this is obviously an invasive procedure. And then we can do ureteroscopy. Where you take an endoscope and go through the ureters, that would be an ureteroscopy. You go into the bladder and into the ureters. This is useful for distal stones, the stones that are present in the bladder or in the distal ureters. And you can go there and retrieve the stone. Then earlier this was the main management, like laparoscopic or open nephrectomies or nephrolithotomies. With the development of ESWL and Pcnl, these procedures are not commonly done today. What we do here is laparoscopic or open nephrolithotomy. That is when the stone is in the kidneys, or pylolithotomy when the stone is in the renal pelvis, or nephropylolithotomy when the stone is in between them, or ureterolithotomy. You open the patient or go through laparoscopically and then break the stone that is in the ureter. So that was about the glomerular disorders and renal stones. This is a very important topic to be known, so know it carefully. And if you haven't subscribed our channel, subscribe now. Thank you.